Neguine, why don't you go ahead and give us your rundown on natural language processing in neuropsychiatry, and then I will only pop in if I need to interrupt you.
Sounds great. Thank you so much. All right, so my talk today is about natural language processing in neuropsychiatry. Let's start with this first question of why language? Why do we care about language in neuropsychiatry that much? So imagine you've got pain somewhere in your body, let's say your stomach, and you just tell someone that you do have stomach pain. This might seem very obvious, but when you think about the network, the neural network, it is not as obvious. What happens? The nociceptors or the pain receptors in your stomach get activated, and the pain message goes from the nociceptors to the dorsal horn, and from there to the brain stem, and from there to thalamus and all the related cortical areas. And from there to the language network in the brain. So you can argue that basically the language network in the brain has an indirect access to what's going on in your stomach, and by the same token to every other organ in your body. And then what another important note about language is that, yes, the direct message is I have stomach pain, but what we're interested in mainly is all the information that goes beyond the direct message. The use of particular word order, and even the acoustic features of language, unbeknownst to you, might reveal some information about what's going on in your mind, in your body. Sometimes the feelings are very vague still. You might have a pain somewhere that is still at a level of discomfort, not localized yet. You just feel not so well, but the words will just give that information away. And so we can say that everyday language contains information about the functional status of our mind. But these types of signals that are hidden in language, they're very rich in diagnostic value, but they're often too subtle to be appreciated by the hidden in the observer. For this reason, we use advances in natural language processing in order to so functional value, a human processing in order. And we use different, I'm going to talk about different applications of it in two different types of disorders. One of them is more applied, and then the other one is at the more theoretical level. So in an ideal setting, this is not yet happening in the practice of medicine or neuropsychiatry, but in an ideal setting, we want a patient to come to us and just talk. It can be related to their chief complaint or other topics. And then we feed their language into a neural network, and then we use the neural network for a variety of tasks, and then ultimately the outcome is given to the physician in order to make the diagnosis. Today, I'm going to talk about two applications, one of them in schizophrenia and then another one in neurodegenerative disorders. What is schizophrenia? It's a disorder. It is called a serious mental disorder, and patients interpret reality in an abnormal way. Patients may have hallucinations. They may hear things that are not there. They may see things that are not there. They might have false beliefs about what's going on. They may have paranoid thoughts, extremely disorganized thought and behavior that usually is so debilitating that patients may not have any functions at all. But one problem is that a lot of these symptoms that I just described, when you look at the textbooks of psychiatry, they're very subjective here. What is the line between normal and abnormal behavior? So as clinicians, but we may miss a lot. And a lot of the evaluations are based on subjective evaluation. from 0 to 10, 10 being the worst, how bad is the severity of the voices that you're hearing? So very subjective on the part of the patients and on the part of the and this, of course, this subjective nature of the assessment makes the assessments vulnerable to a lot of bias and inconsistencies across the clinicians. So we're hoping to use tools from NLP to improve our assessments and improve the objectivity of our evaluations. Let's talk about one specific example, semantic density. Here I have two examples. Patients with schizophrenia, especially at the beginning, because at the end, towards the end, they do not talk that much. But at the beginning of the disease, they may talk a lot, actually. So you would sit with a patient for 1 hour in the clinic. The patient talks to you, and then at the end, when you want to write a note about what happened, you just don't know what to write about, because there was no logic. There was nothing coherent in their language. So here we've got two examples. One of them is from, I'm going to talk about where this data is coming from. One sentence is, I think I do have strong feelings for politics. And then the other one is, so you cannot, well, actually I'm supreme, nobody will not try me. These are actual sentences from the participants of the study that I'm going to talk about. The first one is a reasonable sentence, makes sense. The second one, not so much. More words than the first one, but not necessarily giving more information. So we wanted to see whether we can use NLP, methods from NLP, in order to measure the semantic density of language. We got data from Naples, North American Prodrome Longitudinal Study. It's a study that has it's a multi-center study across the North America, and it follows individuals, mainly adolescents, teenagers, who have first-degree relatives with schizophrenia. So the cohort that we studied did not have schizophrenia yet, but they had the genetic risk factor at high risk of developing psychosis or schizophrenia. We got language from these individuals at the first time 0, and then we followed them for 2 years. And then the question was whether they convert to schizophrenia or not. So our first approach to make the language more objective was to use methods. At that time, I started this study in 2014. At that time, Word2Vec was pretty important tool. Now it has changed a lot since then. But at that time, we used this method in order to turn words into vectors. Look at this sentence. We were lucky to find her. Let's focus on the word lucky, a very qualitative term, and we want to turn it into a vector. We looked at all the neighboring words of the word lucky, and you can decide on the length of the window, how many words you want to include. And then based on that, so we just see, okay, word lucky, what are the words that co-appear with the word lucky? And we use a corpus. As a corpus, we used the New York Times. It had about 43 million sentences. It's about 25 years of New York Times. And we did this type of analysis, where the words that co-appear with a certain word with all words that appeared in New York Times. And this helped us create this type of space. It's very tiny, but each little dot is a word. And words that are closer to each other mean that they tend to appear together with a more probability. And words that are distant tend to co-appear less likely. The blue dots are nouns and the red dots are verbs. And then we've got orange, which is adjective, and few green ones that are adverbs. And here this is just a 3-dimensional representation of, I believe that was 202 dimensional space. So this is just representation, 3D representation of that space. And basically each dot will have its coordinates along all the dimensions, and the word lucky would be something like that, a vector basically. And we applied the same method to the language samples that we got from the participants from the Naples study. Here now we've got a sentence from one of the participants, something strange happened today. And now we know that a vector can be assigned to each of the words in that sentence. And then very easily, we can just add these vectors to get the sentence vector. So here we used a method that we called vector unpacking, meaning that are there other ways to get at the sentence vector? Other vectors could be added together to come out this sentence vector, or is this the only way through these black vectors, the only way to get at this sentence vector? If you break it, are there other ways to get at it? And if you think about the highly dimensional space, you know that there would be a lot of constraints. So not every summation would be possible. For this particular case, we just got, when we broke it to other possible summation, we call them component vectors. As we did this type of analysis to all sentences provided by the participants, we found a correlation between what we thought as clinicians as semantically rich sentences and the number of component vectors that went into it. So we defined semantic density as the number of component vectors, the red ones, over the number of words, the black ones. And for this particular case, we got 0.75 as the semantic density. So it's basically a value from 0 to 1. And this is what we got. We did this type of correlation, not just among the clinicians, but we got many participants from Amazon Turk, and we asked them to just give us their subjective assessment of semantic density, and made the correlation. And we found very high correlation between what this algorithm gave us and the subjective judgment of Amazon Turk participants. So for this sentence that we saw earlier, well, I think I do have strong feelings for politics. We got semantic density of 1. For the other sentence, I mean, it seems as much as we want to believe we matter in the universe, I don't think there is really anything that suggests that we do. This was from a participant that was very philosophically oriented. And for this sentence, we got semantic density of 0.93. For this one, sometimes I get nervous and I get worried about time and I can't look at the clock. For this, we got a semantic density of 0.62. If you look at the sentence, you see that I get nervous and I get worried are pretty much saying the same. So the participant used more words without conveying necessarily more information. So for that reason, the semantic density dropped to 0.62. And then for this sentence that we saw again earlier, so you cannot, well, actually I'm supreme, nobody will not try me. We got the semantic density of 0.13. So we asked the question, okay, after 2 years, we know that which individual ultimately converted to psychosis, to schizophrenia. And we got their language from 2 years prior. Can we use this measure on time 0 to predict who will develop psychosis after 2 years? And the answer was that with 80% accuracy, we could do that. Here's the result of the logistic regression that we got. And you see some of the false and positive cases, and the overall accuracy was 80%. We repeated the analysis. This time we shuffled all the words within the text because we wanted to see, is it about the words or is it about the meaning? The word order also matters. when we shuffled all the words within the text provided by an individual, we no longer saw the effect. So the shuffled text, the semantic density on shuffled text was no longer able to predict conversion to psychosis. So the first part of the talk about schizophrenia was about making a qualitative measure such as semantic density more objective. The second part of schizophrenia is about discovering symptoms that are easily missed. I don't know how familiar you are with psychoanalysis, but during training in psychiatry, we learn how to not just listen to what the patients directly say, but also read in between the lines. And this is very subjective. And among clinicians, there are lots of disagreements about what the patient actually meant. And there's a lot of over interpretation of what the patient actually said. But are there ways to go beyond, objective ways of going beyond what an individual directly says? Earlier, we talked about this relatively easy method of turning sentences into a vector that summarizes all the word vectors that go into a sentence. Here, we evaluated all the words in English that had highest similarity with the sentence vector. When you turn words or sentences into vector, you can do all kinds of calculations. In order to measure the similarity between two concepts, you can easily measure the cosine similarity between the two vectors. Pretty standard method. For instance, for this sentence, something strange happened today. If you just compare or evaluate the similarity between this sentence and the word shiny, they're not really similar semantically. So for this, we got a cosine similarity of about 0.2. On the other hand, the word creepy had a much larger cosine similarity. Makes sense. It's more similar semantically to the sentence given here. So then we ask, okay, if we list all the words that had the highest cosine similarity and the ones that are most representative of patients who convert to psychosis as opposed to a baseline, what are those words? Before getting to what those words are, what was our baseline? We needed something to compare the individuals who converted to schizophrenia with. For that reason, we used the language of 30,000 individuals from Reddit, and we just analyzed their text. And we just asked the question of what are the words that are most representative of the language of patients who convert to psychosis versus Reddit users. This is the space. A lot of it represents the structure of the language acquisition. When we got the data at time 0, the participants participated in an interview, a structured interview. So a lot of the numbers and words and such as the months that you see just represent the structure of that interview. But there was a region that was very unique to these individuals. Just take a look at it. Hear, chant, sound, voice, loud, whisper, utter. These are words that all are related to auditory perception. We know that in schizophrenia, one of the most common symptoms, one of the earliest symptoms is auditory hallucination. So the question is, why are they talking about auditory concepts so much? And the important part is that they did not use the word utter or whisper directly. They used a sentence that had high cosine similarity with these words. So if we just did like a simple word search, we could not come up with this space of auditory words. Then we asked, just out of curiosity, we wanted to know what were those sentences that had high cosine similarity with this space. Here we have a few examples. These are actual sentences from the individuals who did convert to psychosis. You know, I talk to myself, but I don't. I don't know if it is me. I mean, if I talk to myself in the mirror, you know, I'm talking to me. But how can I have a conversation with myself? I say stuff in my head as if I'm talking to me, and it's funny, and I laugh like I didn't know that I was going to say that. This is interesting because auditory hallucination usually does not happen all of a sudden. There are stages to it. Very early on, an individual might only hear their own thought. It gets a little bit louder. It gets louder and louder later to the point that the individual cannot distinguish whether it is a thought or a voice coming out from their head. And sometimes they turn around because the voice is so loud that they really think that the voice is coming from outside. So these are the stages, but at this point, it is very early. The patient is confusing his own voice with a thought and was kind of perplexed, like, why, how can my mind tell me something funny or a joke that I've never heard? How can I laugh at my own, what my brain is generating for me? The other one, a very different person in terms of personality, he said, I would hear something that sound like a plane engine or like really, you know, a really far off motor. It never went away entirely. It's gone a lot more in the past couple of months since Christmas. It just sounds like that. It sounds like a little flame or a cellular, a digital motor. Here you see kind of bizarre association between a flame and digital motor, why a flame would have that kind of sound. So you see these a lot. Interestingly, because the conversation was very long, the interview was about 2 hours. And a lot of these things get missed. We're focusing on this sentence, and yes, it does sound abnormal, but it was a long, like a 2-hour conversation. And at the end, when the clinicians were asked to rate any abnormal findings, they did not actually rate auditory perception as abnormal in these individuals. It was just lost in the long conversation. So we asked the question, can we predict conversion to psychosis using the voice vector? Here we were able to predict psychosis using this vector with 83.3% accuracy. And when we combine the two measures, the first one, semantic density and voice from the second part, we got to an accuracy of 93%. So basically, with these two variables, we were able to make two qualitative evaluation objective, and using those objective measures to predict psychosis in 2 years from the onset from the time that we got the language first. Next, I will talk about neurodegenerative disorders, but I will stop here to get some questions.
Perfect. And we do have, excuse me. All right, we do have some questions. So we'll try not to take up too much time so that we can make sure to get through everything first. So first question, and I apologize if I butcher anybody's name. This is from Magdalena, is how I think you pronounce her name. How do these types of analyses account for inherent differences in structure of language in the used New York Times corpora written language versus study data speech? An example could be different topics or co-occurrences, frequencies, grammar, more colloquial use of language.
Very good question. Yes, we agree. First, let's say that we use New York Times. We started using New York Times because it was the largest corpus available. Written languages are they're larger. There are some transcribed spoken language. Recently, we've been using those, such as Switchboard, or there's Santa Barbara. But like this one, we talked about 48 million sentences. So multiplied by 10, maybe, because maybe each sentence has about 10 words. So it's a very large corpus. When you compare it to Switchboard, it only has 2.5 million words, not even sentences. So we started with New York Times just because it was much larger than any other transcribed language. But we did replicate the results using Reddit. It is more casual conversation. And surprisingly, there is a lot of correlation in terms of like word frequency, syntax frequency. There's a lot of correlation between the two. And we replicated the exact same results using Reddit, which is more casual. Recently, for another work, not this one, I compared New York Times and Switchboard. Again, we got the same results. So it's interesting. I mean, a lot of these are new, right? So it's a very good question that you raised. A lot of these things are new. We just have to test them. But for our case, they did not make any significant change to the result.
And then are these analyses looking only at the semantic density for each sentence, or some other composite measures were computed for full patient's utterances?
I don't know if if there are any other examples of what specifically they're talking about. Short answer is yes. We were just in that particular analysis, we were interested in semantic density because it is one of the major indicators of mental health or mental disorder. So we were interested in having an objective measure of that. If there are any specific examples that you're thinking about, let me know.
And then this is from Jin Wu. Hi, when you said you were able to predict psychosis at 86% accuracy, do you mean the true positive rate of your algorithm's predictions?
So not just that. So accuracy would be true positive, and also, so if you look here, so we've got 4 squares. So accuracy would be the summation of this square and this square divided by all 4 squares. So the other one that you said would be sensitivity, but accuracy takes into account both squares.
Okay, and then Ishita, I want to say I do see your question, but I'm going to save your question for the end because I feel like we could talk about that one a lot longer. This is from Thomas Choi. Would your project have the ability to apply to different illnesses?
Good question. Maybe for the first part, semantic density, yes, because that's something that we see in other disorders such as neurodegenerative disorders, Alzheimer's. We see that as well. Like people talk a lot, but they don't make much sense. Yes. I believe for auditory hallucination, it will be the second part that measured voices. I think that is a little bit more specific to schizophrenia or any other disorder such as drug use or abuse, because people may have auditory hallucination with that too. So it should be specific to syndromes that do have that type of symptom.
Okay. And then one person wanted to ask if you could please explain again what is the definition of the semantic density.
Right. Let's go back quickly. Okay, here. So we said that each word has got one vector. Imagine it's like 200 dimensional space, and we just add these vectors to get the sentence vector. Let's think about the number 8. What are the ways that we can get at this number? We can say it is 1 + 1 + 6. Or we can say it is 5 + 3. So there are different ways of getting at that number. There are different ways of adding vectors. So we asked if we break sentence vector, just like how we broke 8 into its components, how many component vectors we get. again, since it is a highly dimensional space, we cannot have any possible summation of vectors. So there's some constraint, and we will have limited possibilities of adding vectors to each other. Sentences that are meaningful to us make sense. They would have the exact number of sentence vectors as component vectors, and they will have perfect semantic density of 1. But sentences that have a lot of repetition or overlapping meaning, you do not need as many component vectors to make up the actual sentence vector. So you may have only 2, and then that will give you semantic density of 0.5.
Okay, and then we'll do one more question before moving on. This is from Christopher. Is there a way to ask the question by voice? If not, from my experience, there is little issue with discrepancy in the clinician picking up on psychosis. But have you considered the utility of the algorithm for assisting non-trained, like EMS or social workers?
This is something to be done. So we are just at the level of research. Hopefully we can replicate these findings at a larger scale, and then the goal is to have apps that, like, you give patients your cell phone, just record the voice, transcribes it, and the algorithm runs and gives you a probability of, or the possibility of, developing psychosis. So this is the ideal, but we haven't gotten to that point yet. But you're exactly right. EMS, I mean, that'll be fantastic. Like, also in neurodegenerative disorders, you ask patients to talk, and then at the end you get like a probability distribution of all possible disorders. So that's the goal. We're not there yet.
Okay, perfect. And everybody else, I know there are more questions, but we'll save them for the end because I want to make sure we get through the next section as well. So Neguine, why don't we go back to you and we'll continue.
Sounds great. The second part of the talk is more theoretical. The other one was very, it was applied, an applied method to predict onset of schizophrenia. This one is more theoretical. It's about neurodegenerative disorder. What are they? They are a group of progressive neurological diseases that cause the brain cells to die, and the brain becomes smaller as a result of that. Depending on where in the brain we have loss of brain cells and what proteins, what pathology is involved, we have different types of neurodegenerative disorder. One of them could be like Alzheimer's disease. It could be frontotemporal dementia. This painting, by the way, is from my friend for an event to respect patients with neurodegenerative disorder. She had this very large painting. So there's a story behind each of them, but we can talk about it later. But the disease that we're going to focus is primary progressive aphasia. It's a type of neurodegenerative disorder, but what is unique about it is that it specifically targets the language network in the brain. So patients come to us and they're very high functioning. They go to work, they do everything, but there's something wrong in their language. There are different things that can go wrong. Maybe they cannot access certain words, or maybe their syntax is not so complicated anymore. We are going to talk about a subtype that is called non-fluent. And these individuals have neurodegenerative process going on in this part of their brain, left frontal insular, or frontal mainly. When they have loss of brain cells in this region, their language becomes effortful. They will have long pauses, and the rate would be slower. And the grammar becomes a lot simpler. We have a test, we have a picnic picture that it's been there for a long time, for decades. We've been using that picture, so just a drawing, simple drawing of a family at a picnic, and we ask individuals to just describe what's going on. A healthy speaker might say, I see a woman pouring some drink into a cup. But a patient with non-fluent variant or NFBPPA would say, woman pouring drink. Or they may say, woman pouring. Or they may say, woman wine. Okay. The first thing that we can notice here is that, yes, the grammar is definitely simpler. The structure is simpler. The first sentence from the healthy control has two clauses in it. I see a woman who is pouring some drink into a cup. And we have embedding of two clauses. So it's a complex structure. Patients with NFE-PPA cannot do that. It's very flat and simplified sentence. And there are other things going on. Other than the structure, there are some word level deficits. What are those? They do not use into some, so we call these function words that, determiners, pronouns, prepositions. They do not have many of those in their language, but they do have a lot of nouns and verbs. We call them content words. So they keep them, but they drop function words. We also see like woman wine, that's a sentence, but where is the verb? And then when we compare the verb like pour versus see, this is interesting. They use verbs that are semantically richer, or what we call heavy verbs. We have light verbs such as go, take, do, be, have. They're light, like compare give as opposed to donate. Donate is a heavy verb and give is a light verb. So they use a lot of heavy verbs. So what's going on here? And most of the verbs are in the ing or gerund form. Here is a summary of what I just said. So the dark blue is healthy control. And the red one is the NFE-PPA patient. So as I just said, NFE-PPA patients use more content words. They use more nouns, they use more heavy verbs, and they use verbs in gerund or ing form. What's going on? What has been a prevailing view about this is that this is a syntax problem, meaning that verbs are very syntactic-y, so they drop it because they have a damage to their syntax processing center, or they drop a lot of function words. They're also syntactic-y, like prepositions, they have a lot of syntactic role. But how about heavy verbs? They're not syntactic necessarily. Or why ing form? So there's problem with this theory that it's being very common, and it is not explaining all features. Can NLP help us explain what's going on? So any thoughts? Let's look at these features together. Anything similar, anything common to all these four? We asked healthy individuals as an experiment, we asked healthy individuals to describe the same picnic picture using only 1 to 2 word sentences, only 1 or 2 word sentences, and doing the same thing. We saw the exact same pattern. Almost all of the words that they used were content. Almost all of it were nouns. Almost all of it were heavy verbs, and most verbs were in ing form. So we were like, okay, these are healthy individuals. They do not have a damage to their brain. So why are they behaving exactly the same as NFE-PPA patients? And the problem is even more pronounced because we push the problem to the extreme. So this raised a question of maybe there is some problem in the language production of patients with NFE-PPA. And for that reason, just like healthy controls, they're responding to a deficit. I'll talk a little bit more about that. But we thought maybe all these 4 features, what is common in them is that all of them have low frequency. They're words of low frequency. Let's talk about word frequency because this is a very important concept in linguistics, even in natural language processing. With the help of automated techniques, we can analyze large text. We just had an application of that. We talked about New York Times. I think this one is also from New York Times. We can get simple count of words. The is the most common word in English, not a surprise. And here we can get the simple count. But since working with the raw count is difficult, here we got the log frequency of the same number here, and we work with this column, the log frequency. So words, what are the most common nouns in English? Any thoughts? What is the most common noun that English speakers use? Year, person, day, house, time. These are very common, the most common words. And then in New York Times, one of the least common nouns was vinculin. I didn't even know what it was, but apparently it's a protein in the cell membrane. So this one probably has a log frequency of, I don't know, 0.2, versus these may have log frequency of about 6 or 7. Just wanted to give you an estimate of what these numbers mean. So what about word frequency? There's a lot going on, and from the 19th century, this has been a topic of experiments. According to psycholinguistic literature, less frequent words like vinculin, they're more difficult to be processed. They're more difficult. It takes us longer to read them. It takes us longer to process them. And the brain regions that are active are more when you compare it to words like think or year that we commonly use. From the perspective of information theory, less frequent items have more information. So, for instance, if you compare these 3 words, thing, building, sandcastle, they're very different in terms of word frequency, and they're very different in terms of the amount of information that they give you. Thing doesn't give you much information, but sandcastle gives you very precise idea about what I'm talking about. So we asked, maybe what's common in all those features that we talked about is that patients with NFE-PPA are using words that have lower frequency. And this was exactly the case. When we compare the word frequency, the average word frequency that patients with NFE-PPA use, it was a lot lower. And healthy controls, when they were asked to produce only 1 or 2 worded sentences, this got even more extreme. So the alternative view was that, okay, patients with non-fluent aphasia cannot talk for whatever reason that we don't know. Their sentences are very short. So maybe they're just sticking to words that are very informative at the cost of dropping less informative ones, like of, there is not much information in the word the, but there's a lot of information in the word sandcastle. So if they want to drop one of them, they would keep sandcastle and drop the. So this was the alternative view to the prevailing view of agrammatism. In another study that we published earlier this year in PNAS, we showed that actually patients, the more problem a patient has with syntax, like their sentences are simpler. We talked about like embedding 2 clauses versus having very flat sentences. The more simplified a sentence is, they would use lower frequency words. So it seems like they're really trying to compensate for their poor structures by using more informative words. So then the question is, can we test this hypothesis? Is there a way to measure information? If there is a way to actually measure the amount of information in each sentence and compare it to healthy control, then we can test this hypothesis. And the answer is yes. Through natural language processing, we have gotten methods now that can measure the amount of information in each sentence. This program measures surprisal, and this was developed by James Mikhailov, and it measures surprisal. And what is surprisal? Surprisal measures the probability of a word appearing in a sentence. For instance, if I say the girl is making a, so there are many words that can go here, but some of them will have more information. And it's just like a sliding window. First, we will mask this word and try to predict this. And then we mask this word, the second word, and try to predict that. And then by getting the average of the probability of each, we will get the surprisal of the entire sentence. And we expect that and we use a language model to do the calculation for us. So this is my last slide. Just making sure that we have got enough time to get to the questions. But now the question is, what do we expect in order for the proposal to be correct? We expect the sentences from healthy individuals and patients with NFEPPA to have the same amount of information. NFEPPA patients have difficulty processing syntax, but they will get more contentful words in order to compensate. And the answer is, this is actually what's going on. Each little dot is the surprisal, or the amount of information in the entire sentence. This is from healthy controls, and this is from NFEPPA patients, and they're the same. There is no difference between the amount of information that they produce, but NFEPPA patients try to catch up by using another strategy. So this second part was a more theoretical application of just testing a theory behind an important aphasia disorder, and testing whether this proposal is correct or not. It definitely does have some applications, because so far we've been treating non-fluent patients maybe in a wrong way, trying to augment the use of verbs, function, words, because we thought that is the pathology, but that was not the pathology. That was actually their way of compensating for the actual pathology. So it does have some application. Conclusion. So as we talked, language is replete with layers upon layers of information about an individual's mental health. And this information often goes beyond the direct message of the individual. We can use natural language processing methods in order to extract these subtle features. And we can also use NLP in order to test some theories and to see if language dysfunction, how a certain language dysfunction is emerging mechanistically. These are the individuals who helped this work to come to existence. And thank you so much for your patience.
There we go. My video wasn't working. My video wasn't working for a minute, but thank you, Neguine. That was great.
Sure.
Normally, I would steal the screen from you, and I would say we're going to talk about next week's webinars. But we have so many questions that I want to get through that I'm just going to say it really quick. So thank you all for joining. We'll get to questions here in just a minute. Next week on October 19th, we'll have a webinar on reliable and reusable Python script sharing, specifically with the Neguine analytics platform. And so that'll be on October 19th at 10 a.m. Pacific. We're going to be, talking about how to build reliable and reusable components with Python scripts. How do we use that in the Neguine platform? And then, how do we share those as well? And then on October, I think it's the 26th. Yes, October 26th. We'll be doing the ultimate guide to AI infrastructure in 2022. That'll be at 9 a.m. Pacific on October 26th. And that'll be with Daniel Jeffries. He's a managing director of the AI Infrastructure Alliance. So that's all I'm going to say about those. Now we're going to get into questions. Hopefully we can get, I don't think we'll get through them all. There's too many, but we'll do our best to get through as many as we can. So first, if you are the person who is asking if Dr. Razai is looking for interns, I have no idea. Connect with her on LinkedIn. That's what I would suggest you do. I'm not going to put you on the spot with that.
Twitter is the easiest. I rarely check my LinkedIn, so yeah.
Follow her on Twitter. So let's see. First question, given that the models are not 100% accurate, are there any patterns of characteristics among those who were inaccurately categorized by the algorithm? An example is like participants who are inaccurately labeled tend to be older, or anything like that.
Very good question. We tried, so the It is difficult. We actually did the analysis to see what's going wrong or why it is calculating it. There are, little things matter. Unfortunately, we want it to be very robust, the methods, but they're like little changes, like even the way we transcribe things would matter. Like, if a patient says, I don't know, if you put, do you put it or not? Do you transcribe it or not? That matters. There are little decisions that make difference. So ideally, all of these should be accounted for. Or age, we did control for age, so that should not be an issue. And I did not mention it during the talk. All the numbers that I gave in this presentation, they were after cross-validation. So we had a set 80%, we just got the algorithm working. And then on a test set, another 20% of the individuals, we retested it. So in order to, just make sure that we are not overfitting. But there's so many variables. We controlled as much as we could, but a lot of them we just could not find out why we got the wrong labeling.
Okay, and next question is from Seth. Do you know if a similar shift to greater density of information in children with language disorders, or did I read that wrong? Do you know if there is a similar shift? Okay. Do you know if there is a similar shift to greater density of information in children with language disorders?
The answer is no, we didn't test that, but in the range that we tested, we did not see, and there was a wide variability. We had individuals as young as, I believe, 11 years old and up to 30. So in that range, when we made the comparison, there was no difference. So age was not a factor, but of course, developmentally, things are very different. And this is a whole different area, how we like language acquisition. We did not test that, but in the wide range of age that we tested, there was no difference in their language or how they behaved in terms of the language.
Okay, and this is from Neo. Is semantic density a skill that can be improved if the person is not an acute case?
Improved, oh, you mean like they get higher? Yeah, this is what we expect. Yes, good point, because especially initially when we have like first time psychosis, there would be like acute phase. Everything goes wrong, very severe auditory hallucination. And then after the acute phase, things do get better temporarily until unfortunately they get another break. So yeah, we do expect them after the acute phase to have a better semantic density, almost close to normal. But then, it's like a disease like that. So it goes up and down, but eventually it is going down. So 10 years from the onset, they will have lower semantic density, regardless of the acute phase.
And I know someone on one of our live streams was asking, if you're the person that was asking if the slides will be available after the presentation, I'll talk to Neguine about that, and they'll either be posted with the recording or they won't be. So just check, once the recording's available, just check the description and there will either be a link to them or there won't be.
That's great.
Okay, so you sort of answered this when we talked about, using NLP in the real world to detect, in an app where somebody would speak into the app and it would give a probability of that. But are there any other kind of real world use cases for the research that you're doing right now? How can we take this and apply it?
Right. So this field is very new, very young. And it's just a beginning. I mean, there are not that very many studies using language models. So it's very new, and clinicians tend to be very cautious. It is like the similarity of it would be like finding a drug or a medication that is using for a small population. That's great, very promising. But in order for the drug to be administered at large scale, you have different phases and it has to be approved by FDA, and then large scale studies check the side effects. And then after it passes all these steps, it will be released. Even after that, there will be problems. So here we should be very cautious too. Like if the program needs to be tested on larger samples, replicate more and more, because it's terrible to just mislabel someone with schizophrenia. Not so much of like missing it, but mislabeling it would be an issue. There is a, long way from first promising results to real applications. And again, clinicians tend to be cautious for good reasons. But it's great that, at least initially we have good results. We're optimistic. It shouldn't take that long, but definitely things need to be replicated and tested.
Perfect. And unfortunately, that is all the time we have for today. So I know, I think there were not more than a few more questions, but we're not going to be able to get to them. So if you asked your question, I would suggest connect with Neguine on Twitter, or I think Twitter you said was best, or you can
LinkedIn I check every 6 months, so that's also okay.
Yeah, so definitely Twitter. You can share your question with her on Twitter, and it'll be up to you, Neguine, to then respond there. But thank you so much for being here today. We really enjoyed having you.
Absolutely. It was a pleasure. The questions were very interesting. I appreciate your time and all the great questions.